Welcome to Season 2 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former Secretary of Maryland's Health Department. Our goal is to bring scientific evidence and experience to the public health news of the day through informative interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. In this episode, Sara Bennett speaks with Dr. Smisha Aggarwal about the role of digital technologies in supporting the COVID-19 response. Dr. Aggarwal is an assistant professor in the Department of International Health at Johns Hopkins, whose work focuses on leveraging innovative technological solutions to address health challenges, particularly in low-resource settings. In this episode, they discuss how digital platforms can help with case management, contact tracing, and treatment, and the important features that decision-makers should be looking for in these digital technologies. Let's listen.
Dr. Aggarwal, thank you so much for joining me today. I wondered if I could start out by asking you about the rationale for using digital platforms in the COVID-19 response in low-resource settings. I'm sure that there are many challenges trying to use digital platforms rather than paper-based ones. What do you see as the critical advantages of a digital platform?
So time and again, we have heard experts identify prompt and effective contact tracing as being critical to managing the transmission of the novel coronavirus. However, the process of contact tracing is extremely resource intensive. It requires a tremendous amount of data to be gathered and to be kept track of, and also imposes a lot of strain on public health departments. That is part of the reason why in the United States, we are looking to hire thousands of contact tracers. In several countries, the public health infrastructure might be far less developed, and there may not be the resources to recruit and train contact tracers. Also, in the absence of infrastructure or very poor, limited healthcare infrastructure, even infrastructure such as roads, it might be difficult to communicate information about potential areas of outbreak. These are some of the areas where digital tools can help speed up the process of contact tracing by facilitating quick and effective communication across different sections of the health system, essentially.
And I wondered if there had been previous experience with using these kind of digital tools to address epidemics previously.
Specifically in West Africa, where there were, during the Ebola response, several instances where digital tools were used quite effectively. So the challenges notwithstanding, digital tools can be used, for example, just to communicate critical information. In Liberia, a platform called mHero was used by the Ministry of Health to send information to thousands of healthcare workers' mobile phones. And this was just a way to rapidly disseminate healthcare information to contain the virus. Similarly, healthcare workers were able to send information about suspect new cases to the Ministry of Health through an SMS system. The information was collected and was acted upon quickly by the ministry. So it's a simple yet powerful tool, and it allows for reporting and tracking of new cases. It might also be used, such tools might be used to confirm lab results, of sharing reference and training materials, and so on. Just essentially coordinating care across various clinics and healthcare providers. At a slightly outside of the direct patient-provider interaction, for planning purposes, access to real-time information on population mobility. In the case of West Africa, which is one of the most densely populated regions of Africa, having access to this real-time information can help show us where people have gone after leaving an area of transmission and provide some insights on where new cases might appear.
I know that you've recently been working on this report for the Bill and Melinda Gates Foundation, where you review different types of digital tools and assess how they might be able to help health systems in low-resource countries in the fight against COVID-19. In the report, you develop a use case that describes exactly how digital platforms could help. I wondered if you could walk me through that briefly.
Yeah, absolutely. So the report is targeted at program managers and decision makers to understand whether a digital solution can strengthen the process of case management and contact tracing. And then, if indeed a solution makes sense, then what type of capabilities might we be looking for? And so, to demystify the process of digital contact tracing, we break it down into a situation where to walk the user through a hypothetical situation in rural Uganda. So, for example, let's say a woman travels 5 miles by foot to see a doctor to get tested for COVID-19. With how rapidly the coronavirus has spread, healthcare providers haven't been able to keep up with the evolving protocols. But a provider may use the help of a digital protocol to guide them through the process of history taking and symptom assessment. As protocols evolve, these protocols can be updated automatically. This can overcome the hurdle of training providers. And then if a patient's mobile number is recorded, then the doctor may also just message the woman her test results along with instructions for isolation. So that would prevent the woman from making this long journey back to the clinic to get her test results. And also it would limit the further risk of further transmission. So in the case of contact tracing, not only do you want to trace the contacts, you want to follow up on how these contacts are doing and make sure that they can be immediately referred to a testing facility and care if they develop symptoms. This too can be done by text messaging or by using certain applications. So for example, in our report, we talk about if a contact tracer immediately makes note of all the contacts of a confirmed case and feeds the numbers into a digital system, then the process of notifying the individuals of the potential exposure can be automated in part. And that can, of course, reduce the burden on the public health departments.
And when you were describing that use case, Dr. Agarwal, you talked also about how it could take some of the burden off of the client herself so that she perhaps doesn't have to walk the 5 miles back to the health centre. I wonder if you can talk a little bit more for me about what are some of the considerations with the use of these digital tools from the perspective of the client or the consumer.
Often we find that when decision makers are considering a digital solution, there is a tendency to become enamored by shiny objects. And I think maybe the starting point for selecting a solution needs to be to focus on the people. Who's going to be using it and for what purpose? Let me use the example of when individuals are reporting on their symptoms using phone apps. This type of approach, it's called participatory syndromic surveillance. It's been used to study transmission and to understand clusters or hotspots where individuals can be informed about their risk of exposure by being in a particular location. Let's say the type of technology that's often used for this is Bluetooth, where people use Bluetooth to share information about their location. But we must consider whether users actually know how to activate Bluetooth and then how comfortable they are with sharing personal information. And most importantly, we must consider whom we are leaving out. So in case of this specific technology, users need a smartphone and they might need to know how to use certain applications. So in the US, about 80% of the population uses smartphones, but let's think about who doesn't. It's mostly people who are at the highest risk of COVID, older adults, marginalized and disadvantaged communities, people who are at social or other economic disadvantages or speak a language other than English.
So you're saying, Dr. Agarwal, that it's really important to think about the profile of your users when you're choosing which type of digital platform to use.
Absolutely, yeah. So thinking about the profile of the user, and there are, of course, a number of other considerations around costs, which the type of technology that you use has cost implications, and that is one of the many other factors that might be considered.
So maybe I could ask you a little bit more about that question. I presume that there's a mix of digital platforms from sort of more proprietary and likely more expensive ones through to open source types of digital platforms. How do these kind of issues factor into decision making in terms of deciding which of the different platforms to use?
Let's see. So, given the urgency of responding to COVID-19, expanding on digital solutions that already exist, for example, in a given country, and that can be minimally adapted for response, might lower the risk of failing or being ineffective. Also, when users are already used to a system, the learning curve is not as steep and they can adapt to a new functionality. So one of the considerations might be to use an existing system and just configure it for the specific use case. The platforms that we discuss in the report, for example, already have an established presence in several low-income countries. One other critical aspect that has implications for costs is this idea of using open source technology. Open source is sometimes touted as being an indispensable advantage. It essentially means that the source code of the software is free to use. It's often misunderstood to mean that the platform is free to implement, which is not the case. There are still costs associated with adapting the software, implementing it, and continually maintaining it. So in the report, we cover several platforms that are considered global goods and they have open source code. But there's varying levels of support and costs associated with adapting the tools. Some of the platforms may have trained personnel and skills that are available in a given country, and others may not. So if decision makers are thinking about investing in a system, they may want to ask themselves whether they want to be dependent on an overseas programmer to provide technical support. Given that these investments are being made now and they are likely to continue beyond COVID-19, it has tremendous implications downstream around local ownership of the platforms. In some cases, proprietary software that are custom built for a given location with local ownership and local resources, human resources to adapt and maintain it might be preferable to the open source technologies.
We've been talking primarily about the use of digital platforms in low and middle income countries in the fight against the novel coronavirus. But I wonder to what extent these kind of platforms are being used in the US and how might the considerations differ in the context of the US?
So in the US, we often depend on technologies that are dependent on smartphones and on some kind of smartphones, and they use technologies that are a bit more advanced than in several low-income countries. In several low-income countries, the types of devices we use tend to be more basic. In the US, there's reliance on user-generated data where users are actually reporting their symptoms or filling out surveys to report their symptoms. In several low and middle income countries, we are still talking about tools that are based out of healthcare facilities and essentially facilitating communication between providers and patients or different levels of the healthcare systems. One example that comes to mind in the US is the city of San Francisco has a partnership with the developers of ComCare. ComCare is one of the platforms we've covered in our report. And it is to adapt the existing ComCare system to engage people who test positive for COVID-19 and then identify their recent contacts. Public health workers can then follow up remotely with any individuals who've been identified as contacts. Also, the contacts can receive text messages or phone calls daily for 14 days to monitor their health and symptoms. And so this specific example is not dependent on advanced technologies, and I think one that really makes sense and addresses the issue I brought up earlier of thinking really about the types of inequities that we might be contributing to by the type of technology that we use.
Thank you very much, Dr. Agarwal. So, reflecting on our conversation, if I had to identify sort of two of the bigger takeaways, I guess they would be, firstly, the very critical role that digital technologies can potentially play in facilitating contact tracing. And certainly that seems to apply to low and middle income countries as well as high income countries. And then I think the second point that you've made that has really stood out to me is around the importance of usability, thinking both about clients, but also about health staff and their familiarity with these type of platforms and how usable they find them to be. Does that sound like a fair summary of some of the key things we should be thinking about as we approach the use of digital technologies in such settings?
Yeah, absolutely. I think that does sound like a fair summary. I do think that in using digital technologies, starting with the perspective of the user is one of the most critical pieces that we should consider.
Excellent. Well, thank you very much indeed for joining me today.
Thank you. It was a pleasure.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Lamari Morales. Audio production by Spencer Greer, Niall Owen McCusker, Cian Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Thank you for listening.